Start recording, you can start, I guess.
Okay, so this one was designed to like trick most of you, but I see that you managed to get the right answers. The first one, DCT absorbs most of the filtered load. This is not true because it's actually the proximal convoluted tubule that's doing about 80% of the reabsorption of the filtered load. The next one, the PCT is responsible for obligatory concentration and the loop of Henry facultative. This is true. There's nothing more to it. The next one, it's actually the opposite. Instead of reabsorbing potassium and phosphates and excreting sodium and calcium, it's the opposite because under the influence of aldosterone, we're able to reabsorb Na and secrete potassium, and under the influence of the parathyroid hormone, we're able to reabsorb calcium and excrete phosphates. So that one's untrue because it's the opposite thing. And then the next two choices, it's similar over here that the opposite is true, and that's why the statement is false. So the medullary part is actually responsible for water reabsorption under influence of EDH, while the cortical part is responsible for uh, the ion balance, and that is under the influence of aldosterone. So I hope that's clear. Does anyone have any doubts? Okay, if not, I think we can go to the next question. Okay, so see, you've gotten most of the answers, right? So the first one, yes, it's true because these tend to be like fecal contamination of probably the urethra and then an ascending infection from there. So that's why the second option is false because it's usually ascending unless you have some sort of obstruction and you have a blood-borne infection that's able to infect the kidneys. Okay, then the next option, this might have been a bit tricky, but it's mentioned in scripta that during the acute phase of pyelonephritis, you have diminished reabsorption of sodium, and as a result of that, it might manifest with hyponatremia. So that's a little fact over there. And leukocyte cast may be observed. That is true as well, because since you have this infection, you're going to have an inflammatory response from your body, and then you'll have all these like white blood cells clogging up the tubules, and then you might observe cast because of that. So if we don't have any doubts, then we can proceed to the next question. Okay. Okay, so over here, the first one is false. It may have not been worded the best way, but basically what I wanted you guys to understand is that tubulointerstitial nephritis is abacterial in origin. So the source is not a pathogen, it's usually something else, some sort of allergic response or some sort of damage because of long time abuse of certain medications or something, but it's not a pathogen that's causing this. Normally, it's pyelonephritis that is like because of some sort of bacteria or something. So that's why the statement is false. Now, the next one, can occur as an allergic response to drugs. Yes, it's true. Then third statement, damage is mediated by immune cells. This is also true. And yes, we can also observe eosinophils in urine as like if there is an allergic response, it's obvious that you might observe eosinophils. So I think this one's pretty clear. So we can move to the next question now. If you have any doubts, don't hesitate. Just put it into the chat box and then we'll get to you later. Okay, so yeah, it looks like you've all picked the right options. Most of you have. So the first one, it may occur after 1 week of aspirin or analgesic therapy. This isn't true because it's too short of a time. Like, sure, these things could cause tubular interstitial nephritis, but you would have to be on it for like months to years to see the kind of result we're talking about over here. Next question, that it causes tubular cells to transform into fibroblast-like cells. Yes, this is true. And this can lead to kidney fibrosis and then to like chronic kidney failure as a result of it. Then option C, phenacetin is metabolized to ROS, the reactive oxidative species. This is true, but it doesn't cause cortical destruction. It's accumulating in the medulla and causing destruction of the papillary trips predominantly. So because of that last part, the statement is not true anymore. And it can occur from consumption of contaminated wheat. Yeah, it's true. Like Scripta, it mentions the Balkan endemic nephropathy, which is occurring as a result of wheat contaminated with aristopolic acid due to a plant that grows next to it. So, yeah. And if we don't have any doubts, then we can proceed to the next question. Okay. So the first one, proximal tubular acidosis, is a defect of H plus excretion. This isn't true. It's actually a defect of bicarbonate reabsorption because of the defective enzyme carboanhydrase, which is causing the acidosis. Then the next question, yes, it is possible to have glycosuria despite having normal glycemia, and the disease is called renal glycosuria, and it's because of a disorder of glucose reabsorption. Then about renal diabetes insipidus. Yes, it can be caused due to hypokalemia, but the congenital form that occurs because of defective ADH is an X-linked disorder and not an autosomal dominant disorder. So that's why the statement isn't true anymore. And then the last one, Distal tubular acidosis is a disorder of H plus secretion in alpha intercalated cells. Yep, that statement's true. It's a fact. So if we don't have any doubts, I think we can go on to the next part.
Okay, I'm glad everyone got it right. But I'll just explain the options just in case anybody has some doubts. So, vesicoureteral reflux can only be congenital. That's definitely wrong because we know that there's a primary and a secondary form, which basically means that there's a congenital and an acquired form. So, the congenital forms are anatomical variations that might cause some retention and thus reflux of urine. And some acquired forms will be quite similar. So, anything that will block the urine to prevent it from going forward, and thus it will accumulate and go backwards instead. So this can be anything that can where there's like an hypertrophy of tissue, for example, benign prostatic hyperplasia, or anything that can narrow the bladder or the urethra. So for the second option, results in intrarenal renal failure. That is not true. It's postrenal because it has to do with the outflow tracts of urine, then progresses from mild to severe by affecting the calyces first and then the pelvis. That is not true because the direction of affection is basically the backwards direction or the backward flow of urine. So it's going to be from the renal pelvis and then to the calyces and then the renal papilla, and then it will press onto the cortex to cause cortical thinning. Most common clinical features is repeated UTIs. Yes, this is true because you can imagine there's retention of urine and that can predispose to UTIs. If there are no questions, we can move on. Okay, so for the first one, renal stones, most common stones are X-ray positive. So you should note that the most common renal stones are calcium oxalate, and calcium deposits should be visible on X-ray, the same way calcium in bone is visible or calcium in calcifications in vessels are also visible. So calcium oxalate stones, which are the most common, should be X-ray positive. May result in infections and hematuria. Yes, this is true. The stones can cause retention of urine, and as I mentioned previously, that predisposes a person to UTIs. And the stone can also cause mucosal irritation, which can cause bleeding. May be caused by infections. Yes, this is true. There are two ways you can think about it. One of them is that the crystallization nuclei from bacterial infections are sites where minerals aggregate and then they can crystallize. And the other thing is the protease vulgaris infections, which can cause truvite stone formations occur when it releases urease and it makes the pH of the urine more alkaline, which again predisposes the minerals to aggregate and form stones. Can may be mistaken for appendicitis. Yes, this is true, but it really depends on the location of the stones. But generally, it will cause some kind of colicky pain, which means the pain will come in phases. And because there is some kind of visceral irritation, you can imagine that there will also be signs such as nausea and vomiting. But to really differentiate between the two, you would have to do labs and imaging.
So for minimal change disease, um, let's go through the options. First of all, most common cause for nephrotic syndrome in children is correct. Uh, Yeah, this is the most common cause. There is also a type that is in adults, which is associated with Hodgkin's disease and leukemia. In children, it's usually after, some kind of respiratory infection or some routine immunization. Responds well to corticosteroids is correct. Usually, it's because the minimal change disease is caused by some T cells releasing cytokines, and the corticosteroids works on the T cells to decrease the cytokine release. If this kidney disease, not minimal change disease, but if there's a kidney disease that does not respond well to corticosteroids, usually then you need to do a kidney biopsy and look under the light microscope. It's usually focal segmental glomerulosclerosis. That's the difference. So minimal change disease, both are nephrotic syndrome. Minimal change disease responds to corticosteroids, and focal segmental glomerulosclerosis does not. And you need for that kidney biopsy. For shows immunocomplex deposition on immunofluorescence is wrong. The minimal change disease is because of cytokine injury, basically causing podocyte food process effacement and loss of the charge, and consequently nephrotic syndrome, hypoproteinemia, loss of proteins more than 3.5 grams per day, and edema. And commonly progresses to end-stage renal disease is wrong. Minimal change disease is a very benign disease, and usually it can result in acute kidney failure that can resolve very quickly, but end-stage renal disease usually is associated more with focal segmental glomerulosclerosis more than minimal change disease. Minimal change disease, benign, under corticosteroids, it's managed very effectively and easily. That's the difference. So if there are no questions about this one, we can move on. So, nephrotic syndrome manifests with walking edema, which is correct. It's gravity dependent, and it's because of the loss of proteins more than 3.5 grams per day. And the loss of protein should be more than the hepatic production of proteins, resulting in edema. There is hypercoagulation, which is true, but it's not due to the loss of coagulation factors. Usually, it's due to the loss of anticoagulation factors. So the most commonly lost factor in the urine is antithrombin 3, because anticoagulation factors are smaller in size than coagulation factors. That's why there's hypercoagulability, and can be linked to HIV, which is correct. It's a secondary cause of nephrotic syndrome, along with diabetes and SLE, amyloidosis. All of these are secondary causes. Associated with decreased hepatic albumin synthesis. This is wrong. This is more liver cirrhosis than nephrotic syndrome. Nephrotic syndrome associated with protein losing nephropathy. Red blood cell cast in the urine. This is nephritic syndrome, which is associated with inflammation, hypertension, oliguria, azotemia, and mild proteinuria. So yeah, this is the difference. And if you guys have any questions, can ask. If not, we can move on. Okay, so which of the following are true about post-streptococcal glomerulonephritis? So before we go into it, it's a type of nephritic syndrome. And remember, there's three types of acute nephritic syndromes, one that are associated with immunocomplexes like this one. This is subepithelial immunocomplexes. There is antirenal, which is associated with antibodies against the basement membrane, such as Goodpasture syndrome, and one that is associated with like antibodies, ANCA or ANA antibodies, or some uh, Pauci immune, the no immunocomplexes one, basically. So post-streptococcal glomerulonephritis, it can occur after streptococcus skin or throat infection. It's true. Um, this would only, for example, differ in like, okay, so post-streptococcal, you know that there's another complication, rheumatic fever, but rheumatic fever only occurs after a streptococcal throat infection and not a skin infection. But glomerulonephritis can occur even after a skin or a throat infection. So I think that's a difference you need to know. It's a type 3 hypersensitivity reaction, obviously immunocomplexes. It's often present immediately after the infection is wrong, usually takes a couple of weeks. Um, Present immediately after the infection is more of the IgA nephropathies than the post-streptococcal glomerulonephritis. Another thing you can differentiate, know the differentiation of. And immunocomplexes are deposited in the glomerulus is correct because it's a type 3 hypersensitivity reaction, and it commonly leads to chronic kidney disease is wrong. It's acute nephritic syndrome. It's easily managed. Just give them penicillin and they'll be fine. Uh, yeah, if there are no questions, then we can move on to the next part. Okay, I think this is easy. It's considered a variant of IgA nephropathy, obviously. They're closely related, and it's more common in adults than children is wrong. It's more in children and often after some respiratory disease. Skin rash, especially on the leg, is a common symptom. Usually it's like pathognomic that you see a skin rash on the leg, you think about Henoch line purpura, and it presents with abdominal pain and joint symptom, CS. And kidney involvement is not seen in all patients. It's seen in about 50% of the patients. And just remember that Henoch purpura is associated with rapidly progressive glomerulonephritis, and it's also immune complex mediated. So next question. Okay, so azotemia. Azotemia, you can see it in nephritic syndrome because with the proliferation of the mesangium, there's decreased glomerular filtration, oliguria, retention of water, and nitrogen waste, which is azotemia. Azotemia is, I think this is very important, it's not ammonia, and it's also not uric acid. True that the uric acid may deposit in the body with renal failure, but it's not a nitrogen waste. It's related to another pathway like the xanthine and the hypoxanthine pathway, not the nitrogen waste and the urea pathway. Azotemia is related to the blood, the bun and the urea mainly, not uric acid. So I think this is very important. She brings this question every year, so I thought I would include it here. So azotemia, bun, and urea, not ammonia and uric acid. Uric acid does accumulate, but it's not a nitrogen waste as it's included more in another pathway, the xanthine and hyperxanthine pathway. Yeah, I think this is very easy. Palsy immune, basically no immune complexes. So subendothelial immune complexes is wrong. It's more associated with like membranoproliferative immunocomplex mediated glomerulonephritis. And that's seen in like SLE and rheumatoid arthritis. Uh, it's associated with ANCA antibodies, anti-neutrophilic cytoplasmic antibodies, which attack the cytoplasmic antigens of the neutrophil and can cause damage by release of like elastases, proteinases, and myeloperoxidases. Uh, Antibody against nuclear elements, no, that's SLE. And SLE can be both nephrotic and nephritic. Uh, and C3 nephritic syndrome is also a membranoproliferative glomerulonephritis, and it's also associated with immune complexes. So it's not. So pulse immune, no immunocomplexes, usually ANCA antibodies. And it's related to like some small vessel vasculitis, and it can also be part of like, granulomatosis with polyangiitis, these small vessel vasculitis. So we can move on.
Okay, so regarding this question, yeah, it doesn't take several months to a year. It actually happens within days. That is acute renal failure. As for the modern terminology, yes, it is in modern literature called acute kidney injury, and tubular dysfunctions do cause polyuric renal failure. If you remember, the functions of the tubules is like reabsorption of whatever's in the urine. So if it isn't reabsorbed, it basically goes to the tubules much quicker. So if there's tubular dysfunction, it would lead to polyuria, at least in the beginning. Later, it becomes oliguric. And the most dangerous electrolyte abnormality in renal failure isn't hyperphosphatemia, but rather hyperkalemia, because that can cause the cardiac arrest. And then we have ATN, which is not a cause of prerenal renal failure. Rather, it's given as an intrarenal cause of renal failure. However, it is caused by a prerenal cause. It is like a bit confusing, but yeah, it is what it is. So regarding hepatorenal syndrome, it is like a cause of pre-renal renal failure, and the pathophysio department expects you to know, well, at least some detail about it. I think they give it a lot of importance. So it is not a renal disease that causes the hepatic disorder, but it's the other way around, where a hepatic disorder causes a renal dysfunction. And then there's tendency to systemic hypotension. That is true because in its pathophysiology, there's first and foremost portal hypertension, and then uh, in that case, you have leaving of fluids from the vascular compartment into third spaces, and you also have release of vasodilators, so that causes a tendency to systemic hypotension. And as a compensation, there's sympathoadrenal activation. By that I mean release of catecholamines and then even aldosterone to try and get that blood pressure back up again. So that is true, and it is not a cause of chronic kidney disease, but rather it causes acute kidney injury. So intrarenal renal failure, uh, it can be caused due to two things in general, either some acute glomerular dysfunction or some acute tubular dysfunction. So ATN, as mentioned before, even though its cause is pre-renal, it is a cause of intrarenal renal failure and is the most common cause of intrarenal renal failure. Rhabdomyolysis, well, let's break down the term. Rhabdomyo basically means something related to the skeletal muscle, and lysis means breakdown. So rhabdomyolysis is basically increased breakdown of skeletal muscle. This can happen in, for example, severe injuries in crush syndrome, a car accident, or whatever. So in this case, you're releasing a lot of the compounds that's present within the skeletal muscle. And the compound that is of interest for renal dysfunction is myoglobin, and it is something that can cause renal failure. Like myoglobinuria is something that can risk renal failure in an acute situation. So yes, intrarenal renal failure causes a tubular dysfunction. So I know rhabdomyolysis causes a tubular dysfunction, which can lead to intrarenal renal failure. It is not caused by obstruction of one ureter. It requires bilateral obstruction, or for males, obstruction in like the obstruction caused by BPH, which is benign prostatic hyperplasia. Removal of tubular obstruction is followed by a period of oliguria. That is, the opposite is true, where once you remove the obstruction, it causes a period of polyuria because uh, during the obstruction, there is death of the tubular cells, and as mentioned before, tubular dysfunction leads to polyuria. So as these cells regenerate, the newly produced cells are sort of immature in their functions, and therefore there's, let's say, somewhat of a tubular dysfunction after the recovery. So it is a polyuric period. And glomerular cells are not the most sensitive to ischemic injury in the kidney, but rather it is the tubular cells. And that is why we have a tubular dysfunction when there's an obstruction. So regarding dialysis, yes, it is part of renal replacement therapy. Renal replacement therapy comprises of primarily three things, and that is hemodialysis, peritoneal dialysis, and kidney transplant itself. Um, it can be it's not pleural dialysis, but rather it is peritoneal dialysis. Uremic symptoms, particularly like pericarditis and all that, it is an absolute indication of dialysis. So if it is seen in a patient or signs of pericarditis is seen in a patient, for example, through ECG or clinical symptoms, it usually requires, like, it is an urgent indicator of dialysis. Hyperhydration is an absolute indication. That is true, because if you don't treat hyperhydration, it can lead to imminent heart failure, and it can also risk cerebral edemas. And this is something that Ms. Kubova likes to test. And this is something called the dialysis disequilibrium syndrome, which basically occurs because the like dialysis is a rather quick thing, but uh, the movement of, well, let's say, substances across the blood-brain barrier is rather slow, and dialysis disequilibrium syndrome basically, like, the gist of it is that since urea moves is slow to move in through the blood-brain barrier, when you perform hemodialysis, the concentration of urea is higher in the brain than in the blood, and therefore fluid begins to move into the cerebral compartment and therefore causes some sort of cerebral edema. It's so for chronic kidney disease, its most frequent cause is not hypovolemia, but rather hypertension and diabetes. Hypovolemia actually causes acute kidney injury. Renal insufficiency is when the glomerular filtration is between 20 to 50%, and the GFR is not least in uremia, but rather it is least in a condition called end-stage renal disease, ESRD. It risks hyperkalemia. Yes, that is the most feared electrolyte abnormality in kidney disease, and it risks deposition of calcium phosphate in vessels. That is true, because you have especially in end-stage renal disease, you have secondary parathyroidism, which is trying to reserve or retain calcium within the serum. And then you also have decreased excretion of phosphates by the kidney, and therefore it results in formation of calcium phosphate stones, which deposits, for example, in vessels. This can even be seen in X-ray. Renal osteodystrophy, which is like a bone disease because of renal failure, actually occurs later in renal disease, not early, because there's two layers of bone that you have to go through for this disease to occur. And initially, the first layer is affected, and once that's exhausted, then only like you start using up the second layer, and that's when you have renal osteodystrophy. So uremia is not simply the increase of nitrogenous wastes in blood. I think that is azotemia. Uremia is when the uremic symptoms begin to manifest. It most commonly manifests as the symptoms mentioned here. There's risk of encephalopathy and anemia. Anemia is particularly because in uremia the kidneys are dysfunction, and kidneys are actually one of the if kidneys are the releasers of erythropoietin, and therefore that is one of the pathomechanisms involved in anemia. There's also some other things regarding bone marrow depression, but that is something else. And its management is by renal replacement therapy, which is, as mentioned before, hemodialysis, peritoneal dialysis, and kidney transplant. I believe that is all the questions. Do you guys have any questions? Uh, Okay, if not, thank you for attending. And if you do have any doubts, please feel free to reach out to us, and best of luck with your upcoming pathophysiology test.